All right, we are going to get started here. So I'm going to let y'all wrap up things, and in a minute we'll introduce some panelists in this topic and hopefully generate a little bit of some conversation. Yeah, it's Friday. So I appreciate anyone who is here with the topic, with interest in the topic, and hopefully we'll stir some thinking in you. So thanks for coming. So just initially to go ahead and introduce ourselves, my name is Mark Courtney. I'm at UT Southwestern. I'm the vice chair for academic affairs there, so a lot of what I do is think about where people are and where they want to go in terms of career growth, academically, scholarship, research. Jesse Pines, you can introduce yourself. Oh, yeah.
Jesse Pines, Chief of Clinical Innovation at USACS.
Dr. Tur?
I'm Rob Tur. I'm a clinical informaticist at UT Southwestern.
Ellie Alvarez, I'm the Director of Wellbeing at Stanford.
Excellent. So here are disclosures for Dr. Pines, nothing for the rest of us. So this is going to be a brief overview of a very large topic. We're going to look at the intersection of work site, workforce stress, and technology. We're going to talk about clinical work and how it might be made easier with some things. So this is not purely a wellness, well-being talk. This is not purely an AI talk. This is really a talk designed to think about how technology might result in an emergency department works setting that is easier for you to focus on what you want to do, caring for patients and human beings. So a little bit of this is looking into the future. I'm going to turn it over to Ale to move to this topic.
Great, thanks.
Mm-hmm.
So this just got published. So for a while we've been using the professional fulfillment model, and at Stanford we talk about, so the red one is really the institution's effort, because in the past, like, there's this expectation that we as individual physicians, we just have to be better, right? We need to resilience our way out of this, and that's really not working anymore. In fact, they changed the language in the professional fulfillment model from personal resilience to individual factors, because there's many other things in individual factors that come in, including it's important to sleep, it's important to actually go home and be with your family and your loved ones as opposed to just staying at work all the time. And from a systems perspective, that's where the culture of wellness comes in. Can we actually highlight some of these efforts that will allow us to have more time and minimize that impact of work on personal relationships? And can we improve the workplace efficiencies like the EHR? This is a paper that was just published a year ago, specifically on the impact of work on personal relationship. What we're finding is that we've been telling people that it's important to have time to spend time with your family, to do the things that gives you passion, that 20% that give you meaning in your work. But if we don't actually start tracking how much of our work is impacting our home life and how much of that eventually will impact our work life, then we're not really going to advance this. So then there's now data on the impact of work on personal relationships, and you'll see, not a big surprise, emergency medicine leads, even though we actually work a lot less compared to any other specialties, right? We are impacted the most with our work on personal relationships. And so the goal here is to just think of, like, is there an opportunity for AI to make our work easier and not give us more work? And so there's many things here that our panelists will be discussing, including scribes, including like medical decision making, but just for us to kind of like give a preview of things that might be coming for us. I really like this slide because there's 3 studies now that highlights that taking vacation from work is actually good. But did you know that less than 70% of us emergency physicians take more than 3 weeks of vacation a year? 70% of physicians spend some time at work, like responding to emails or doing some EHR stuff, during vacation. It's a big number. 40% would actually spend more than 30 minutes of your vacation day doing some work-related stuff. And so the goal of, like, can we embrace a little bit of technology, a little bit of AI to not give us more work, but to actually give us that true psychological distancing from work? Because the data is also very clear. The more we spend time at work, the more likely we're going to start thinking about, maybe I need to cut back on my hours, and maybe I don't need to work in emergency medicine anymore.
So this is kind of a nice, I think, just kind of model the way I think about this. So, when I'm really kind of pessimistic, I'm kind of trying to think about what things may look like, and I'm thinking about this graph here, where I'm kind of describing the future here and the magnitude of well-being just going down. And these work tool aids, I'm hopeful that they're going to help us, but they're slow, they're sluggish, they're just not really coming as fast as we need them to really help mitigate some of the stress that we're feeling. But then sometimes when I'm really, really optimistic, I'm like, man, this is going to be great. I'm going to have ambient scribes tomorrow, and it's going to make my life so much easier, and just everything's going to be awesome, and our well-being is going to continue. I don't know. Maybe this is a little bit more realistic. We've got some time. Things are going to get better. Yeah, we still have some difficulty. Maybe there's a plateauing, and well-being is at least not going to get worse. Maybe it can go up. We'll see. So I'm going to turn it over to the rest of the panelists to kind of dig in a little bit on what are these things that are going to help, and when are they going to come, and what is it going to look like?
Great. So thanks, Mark. So I'm going to talk a little bit about sort of the AI and some of the work that we're doing at US Acute Care Solutions. So my role, I'm the Chief of Clinical Innovation. Like I say to other folks, it's good to have a non-specific title that sounds important. That's a good career goal for future residents, faculty. So as part of my role, I focus on clinical AI, which over the last year has absolutely exploded. So the question is, what is happening now, and what may happen over the next 10 years, to Mark's point, and how is this actually going to sort of change the trajectory of things like clinical efficiency? Will it actually improve clinical efficiency? Will it actually enhance safety? Reduce variation in the care that one patient gets versus the other patient? Who here watches The Pit? Okay, so what is the one thing they don't do in The Pit? No one charts, right? So in the future, will there be a situation where ambient AI is in the background, capturing what we do, looking through prior records, and coming up with a prior history so we don't have to dig through the EHR? Will AI help us even think about the medical decision-making for the patient based on the context of what's in the electronic health record, in the context of why the patient is there? Is this someone who comes in for chest pain all the time and always has a negative workup? Or is this a brand new finding? What's the old EKG? How does this patient talk about their chest pain? All these different features are I think, happening now and will impact our work in the near term. We are also taking an approach right now that we think that there is facilitating quality improvement. We are actually piloting a number of different solutions. So Box AI, Google Notebook for sort of uploading charts, making some inferences around quality of care. You think about the way that quality of care is currently done today. It is so rudimentary. ICD-10 diagnoses, CPTs, it's so rudimentary. This is going to open up tremendous areas. Is it, to the point of this talk, is it going to reduce burnout? I think the jury's still out on that. What we found in the initial rollout of some of these ambient platforms is some physicians love it. I got the email a couple days ago from one of our APPs. It's like, please never take this away. This has changed my life. And other physicians where I feel like they're testing this as a personal favor to me, and are like, okay, well, Jesse really wants me to do this. I'll try it, and I don't like it. And certain people who we gave them a bunch of stuff and they never even turned it on, right? So that's sort of the adoption curve. Will it take our job? My view is no. It is not going to take our job. It may take radiologist's job away, but it's not. So it's going to take ours. So here are some brief AI use cases. I'm not going to go into super detail. This was from a paper we published a couple years ago in American Journal of Emergency Medicine by my fellow at the time, Marika Kochman. So basically takes from some AI use cases from, symptom checkers up front. So chatbots around getting people to the right level of care. That has, to my knowledge, not been deployed at scale. We have seen some degree of flags within the EHR. I think that is going to be a near-term intervention. Epic does that. So far, the research to date has not shown that's particularly good. I think AI is going to make that a whole lot better. Chart data abstraction, we are working with a company. We're going to be doing a pilot out in California with a company called Abstractive Health. We're also working with Oracle to try to develop some of this stuff. But, going in, being able to accurately sort of summarize the chart. This particular company creates an ED to hospitalist handoff note. We also staff a number of hospitalist programs that creates a draft discharge summary. These are like real time savers, right? If this stuff works. If this stuff works. Ambient AI documentation, that's where we are right now. My grade so far is a B. So B, I don't want to give a B minus because there are companies that are creating. Some physicians and our APPs love this stuff. It takes a lot to customize. Usability is improving dramatically. 1.0 version is sort of like eh. MDM, you're saying that you're working on that. That's really sort of an open, great research question at this point. All this stuff can really create really, I would say, relatively robust MDM, which our clinicians like, our compliance people freaks them out, our risk people, it freaks them out, that there's going to be thoracic dissection in that MDM that's going to get into that note and not be addressed. ED handoffs, I talked about that briefly. ED course, there was a study in JAMA Network Open that did show that using this abstractive health was reliable, less valid than humans doing it. But any sort of LLM you test right now, it could be completely irrelevant 2 months from now, or even 2 weeks from now. So research in this area is tough because you say, well, AI doesn't do this well. That's never true because AI is constantly learning. Differential diagnosis, treatment recs. I saw a really cool program that actually had ingested StatPearl's WikiEM and actually will create a draft plan for folks, which again is going to freak out our risk and compliance people, but it's pretty cool. That's coming. Sepsis flags, clinical decision support. Who here has heard about Queen of Hearts? So Queen of Hearts, this whole concept of what's called an occlusion MI, where that AI can determine that this is an EKG that is about to become a STEMI and is actually better than like 5 master cardiologists looking at the EKG. That is coming. That's going to get FDA approval this year. Admission handoffs, discharge instructions, and then sort of data abstraction, research. So I'll briefly stop here, but the world is going to change very quickly, and there are going to be tremendous opportunities for research and quality improvement.
All right, excellent. Dr. Tur?
Thank you. I love that paper, by the way, Dr. Pines. We have used that several times, and it's really helpful, like in most situations, to have a framework. So this is a really fun discussion to be having. I'm glad to be part of it. What did I do there? There we go. All right, so I'm going to be talking a little bit about the patient connection and how these tools currently and might affect patients versus our own team members. We published a paper a couple years back that demonstrated that since the 21st Century Cures Act information blocking rule was deployed, that there's been an increase in use nationally of patients looking at their portals and their electronic health data during their ED stays. I reran this locally for just UT Southwestern to refresh the data for this talk, and that trend has just continued. People are using it. We're not doing anything to do that. We're not telling them, we're not advertising. People want to engage in their health data and with the tools that support them. And so, what does this have to do with, AI and technology? Well, everybody, this isn't clinicians, everybody is using AI, right? Most adults are using this on a regular basis. Most of them are confident that they don't trust what they're seeing, but that they can't always tell. Many people use this for their health information on a weekly basis. And similarly, they're not confident in the accuracy of what's going on. So, I think we may have perceptions that this is a future thing. People are doing this right now, right? They're not doing it necessarily in the safest of ways. They may be taking your chart out of your electronic health record and throwing it into, public-based generative AI systems to get information about it. And they're often doing this, I suspect, without engagement of the clinicians. And so, I think it is on us to start thinking through where is the roadmap here and how are we going to be a part of guiding our patients in knowledgeable, safe use of these tools. Because whether we like it or not, this door is open and it is not closing. But I think there's opportunities for us as health systems, for if there's any vendors in the room, for us as the greater we to contribute to making this easier for patients, making it integrated for patients, making it safe both for their interpretation of the data as well as safe in terms of stewardship of those data and making sure that they're staying within systems that are built to handle this appropriately. I'm sharing a very, very preliminary paper that was published by a couple of my friends at the Open Notes Initiative, Liz Salmi, who's a patient advocate and researcher, and Kate DeRoche, who's the director, where they said, there are tons of studies already looking at clinical summarization. And as we'll see in a little bit, there's a lot of tools for that for clinicians. Very little talk about this stuff focused for patients. And so in this proof of concept study, they tested 3 different LLMs to see how well they could answer patient questions about a doctor's progress note from a neuro-oncology visit, a type of care for brain tumors. Patients created the questions and the answers from the LLMs, and they were graded by both the doctor who wrote the note and a patient using 8 criteria such as accuracy, clarity, and tone. And take a minute and take a look through the prompt. These are the sorts of questions they were asking.
Complicated.
Everybody had a chance? Okay. I'm going to kind of skip through this because the sample size is so low that I just wanted to show sort of the width of these box plots, mostly to show like, there's maybe a signal here, but this is like a single-digit number of patients, and we don't really know, but I applaud them for setting the framework for the question. And so the reality is, the patients perceive the LLM-driven information slightly lower than the clinicians did, which I think is generally consistent with clinicians' understanding of our ability to communicate things anyway and sort of interpret people's understanding of things. So I think that aligns. But where is this going, right? What are the vendors doing? Where are we going to go with this? And then we can hopefully pivot this back to some other discussion. If you look at Epic's AI roadmap as of April when we submitted these slides, there are 14 actively available AI features, of which only 4 are patient-facing. The CRM, or customer relationship management, something called Cheers, that sort of, if you've ever sort of like dealt with a restaurant and had sort of the back and forth type conversation, it helps to deal with that communication and information capture from a health system to a patient. This isn't really even patient-facing, but we'll give it credit for it. So like questionnaire or patient-reported outcomes translation exists, but that still has to be facilitated by the health system. There is the capability of doing auto-generated patient reminders. And then again, automated message response, which again, at this moment still requires a clinical input and is really more of a clinician helping tool than anything else. Only one is directly patient-facing, which is appointment scheduling using agentic AI. And so there are some features on the roadmap like results summaries, financial summaries, and customer service. But compared to the breadth and depth of what is out there, right, we deployed a pilot of the clinical summarization tools last week at UT Southwestern, and I think many of the people in this audience, knowing where you're from, are already sort of well engaged in this process. It's pretty rich, not for patients. It is really hard to understand what Oracle is currently doing. They are putting a ton of money into this, but there is not really much transparency about what that's going to mean. And most of what's published from Oracle for Cerner, Oracle Cerner, is mostly clinician-facing, sort of assistant-type tools. So we'll see where this shakes out. If anybody is working with this, I think we would all welcome that in the discussion. But the bottom line is that patients are capable and interested in using these tools as well or better than we are. And then we, again, the royal we, should foster rather than stifle this, what I think is an unstoppable trend. As we know, EDs are increasingly able to communicate with patients in real time. There are tools in all of the EHR vendor systems, but many of us aren't using them to their fullest capability. And so integrating all of these things, the AI tools, the ease of accessing their electronic health information, and real-time notification and communication with our patients is going to be really key for managing their experience and letting them benefit from what's happening around them instead of happening to them.
All right, so we have time for at least a question, maybe more. We can turn the room over pretty quickly, but kind of understanding the framework. Any questions for the panelists from the audience perspective? Yes?
Hi, I'm Jeanette Wolf from UMass Bay State. I am a middle-aged woman who is not digitally native, but I'm a lifelong learner. I've been in this game for 30 years. What are the 3 things I should take as a provider that I can use in that shift with my learners?
With your learners?
Anybody. Like, give me 3
Yeah,
things. Like,
three things right now that if you're going to spend your time learning about things, what are the 3 things? Okay.
As the sort of the informatician, what I'll throw out there is you probably have more resources than you're unaware of. And so if you're going to take one thing, it would be to find an informatician that either supports your department or, depending on the structure of your shop, it may be one level away from that. And there may be things available to you, or that you could get out there that you can influence that may not be evident to you. And so you as what vendor system is your? Okay. There are a lot of resources that as a customer you can get on and see what's coming and be a voice to make change. So I would just say, as clinicians who aren't professionally in the informatics space, your voice still matters.
Yeah, I'd agree with that. I mean, I think the one thing people should try now is these consumer-based tools that are for, ChatGPT, Claude, Perplexity, Open Evidence, list is lengthening every week. Like, just check it out, try it. Open Evidence is actually a really cool one where you can log in, it's free, put your NPI in, it will do a literature summary for you that it's pretty good. It's a little lower hallucinations than other LLMs. So, but I would just sort of play with things, see what you like. I mean, I think that for learners, there is tremendous. There are tremendous things that are going to happen. I actually saw something yesterday. One of the companies that we're partnering with, that at the end of the shift, for residents, there's going to be basically a list of things that they saw during the shift, and the AI is going to generate 10 multiple choice questions of here are 10 questions about what you saw, the summary, reflect on this. I mean you can do this something similar with a commercial AI right now.
And I'll just add, I think that from a well-being perspective, better, faster, more efficient, and also with the deluge of information that we're getting a lot more, especially for the learners, compared to what we learned 20 years ago, 30 years ago, we have to be very mindful about that psychological distancing from work. Just because we have easy access to the information does not mean that we're constantly on work. That time away from work is going to be very important, and we really need to be a lot more strategic with making sure that we're giving ourselves time to also prioritize other things that are important for us, including family and personal things.
Judd.
So, about how we could utilize AI, but I haven't seen one where people talk about how we could learn to utilize AI. And so I think it's really important that we don't just focus on just playing with AI. We need to learn how to optimize it. And so I would say, use it in your life. Pick whatever one is free. Go on, I mean, I use Google Bard a decent amount. It ain't perfect, but I decided a while ago I would do one thing every day, like plan a vacation. And it's like the way we're just trying AI right now is like the kid in the back of the car saying, Mommy, when are we going to get there? There's not an answer.
Yeah.
But if they said, Mommy, would we get there faster if we took this highway or that highway, i.e. prompt engineering, you'll get an answer that's, you know, more likely to be right than wrong. And so I think we need to have an emphasis on learning how to do it. Otherwise, it's like handing somebody a stethoscope or an ultrasound machine and saying, go play.
We're gonna wrap up. I'm gonna leave one final comment, and that is, I would also recommend to have a permissive conversation with your learners as to what they are doing. It's amazing how they may be using an LLM in their life to answer a lot of other questions, but on shift they feel like they cannot or should not, or then. So open up a conversation and find out what colleagues are doing, what learners are doing, as we kind of explore that. Kind of building a little bit on Jesse's comments too. Thank you all very, very much. We'll be happy to answer any other questions.